All right, good afternoon, ladies and gentlemen. It's now 2 o'clock, so we'll commence. I'd like to welcome everybody to today's meeting of the Adults and Communities Overview and Scrutiny Committee. Just like to remind everybody present that the meeting will be broadcast live via the County Council's website and will also be available for viewing after the meeting. So obviously normal procedure when you speak, if you can please remember to switch on your microphone and switch it off when you've finished. Make sure that the camera picks up our beautiful looks from the right angle, although looking at mine it's showing the bald patch, so it's not too good. Right, item number 1 on the agenda is the minutes of the meeting held on the 12th of September. Do I have a proposer? Thank you. So it's Councillor Fry and Councillor Lickrish. All in favour? Thank you. Right, item 2 on the agenda is question time. We have received no questions from members of the public. Item 3, questions asked by members under Standing Order 7.3 and 7.5, and we've received no questions from members. Agenda item 4, any other items which the Chairman has decided to take as urgent elsewhere, not elsewhere on the agenda? Any members got anything they wish to? Thank you. Item 5 on the agenda, any declarations of interest in respect of items on the agenda? Councillor Jennings?
Yes, Chairman, agenda item 9, the sleep-in allowances. I'm not sure if I have to declare this, but my daughter is a nurse, the mental health nurse at the Glenfield Hospital. She no longer lives at home. She's married, living in the city, but I'll just put it on record.
I think that's been noted. Thank you. Right, we then have agenda item 6, declarations of the party whip in accordance with Overview and Scrutiny Procedure Rule 16. We have no declaration from the whips. Agenda item 7, presentation of petitions under Standing Order 36. There have been no petitions presented. So I think we now move on to the substantive reports, the first one of which is agenda item 8, which is the delayed transfers of care, which is with our Director of Adults Communities, John Wilson.
Thank you, Chair. I'll just introduce the report and then hand over to Peter Davis to go through some of the detail of the local actions being taken. So the report is to provide committee with information on delayed transfers of care, and particularly how that relates to residents of Leicestershire. We'll also talk through the report about the national targets that have been set, how we are responding to those locally, and the impact that those targets may have on the local authority and the NHS within Leicestershire. Members may be aware that in July of this year, NHS England established through the Better Care Fund planning guidance new targets for delayed transfers of care. These were quite stretching targets whereby they expected all local areas, and by local areas they mean Health and Wellbeing Board areas, so that includes both NHS and social care, to reach a target of having no more than 3.5% of occupied bed days delayed at any one time. So what that means is that of all of the beds in the NHS, in UHL, in community hospitals, but also in any other bed which has a Leicestershire resident in it, no more than 3.5% of those beds should have a person in that bed that's delayed on leaving hospital. That target is a stretching target, but not one that we felt that we couldn't meet in Leicestershire, given the time to meet it. And we'd already set, before that target came out, we'd already set a trajectory to meet that target by March of next year. But NHS England, in their target setting, decided that they wanted that target met by November of this year, which was very challenging for us locally. The County Council, together with partners in the City Council, Rutland County Council and the NHS bodies locally, agreed that we should retain our local target and respond to NHS England with a plan to meet the target by March of next year. However, that wasn't approved by NHS England, and in addition to not approving it, there was a a threat of withdrawal of a significant amount of funds from the County Council, up to £22 million, should we not sign up to the target and meet the target by November. So reluctantly in October, the County Council agreed to sign up to the target. And we'll go through where we are against that target as we go through the report. Just to note, so that everybody is aware of the definition of a delayed transfer of care, the people we're talking about are people who are in hospital, have been admitted to hospital, where a clinical decision has been made that the patient is ready to transfer out of hospital. So the treatment that the person has received in hospital is complete from a medical perspective. They may still require further care and support, but from a medical perspective, the person is fit to be discharged. That a multi-agency team, a multidisciplinary team, it includes social workers, occupational therapists, physiotherapists, as well as the medical staff, have made a decision that the person is ready for transfer and that the person is safe to be discharged. So those three criteria have to be met before a person can be deemed to be delayed in hospital. We report our delays on a monthly basis to NHS England. Unfortunately, it takes 2 months to get that information back in a published form from NHS England. So when NHS England publish national performance and the performance of each health and wellbeing board area, it's 2 months in arrears. That's partly why you'll note that in the report we've given you performance as of August of this year. When we wrote the report, that was the most up-to-date nationally published information that we had. Subsequent to that, we have now received, just last week, the September performance, and I think that information has been made available to committee members separately. So you have got the most up-to-date information as of last week to look at today. I'll hand over to Peter Davis to talk through where we are against the targets and the actions that we're taking to address the improved performance.
Thank you, John. So, obviously, this is a complex system. If we're talking about acute hospitals such as UHL and the Leicester Royal Infirmary, and then right through to specialist hospitals, provision at LPT, so that's the Bradgate unit, the Agnes unit, which is a specialist unit for patients with learning disability. And then we go out to Leicester Partnership Trust community hospitals, and about 11 of those. And then we have relationships with out of county, most notably the George Eliot, Kettering, Burton hospitals, Lincolnshire, and Coventry and Warwick and Walsgrave. So in terms of our performance, from an adult social care perspective, delays at University Hospital, at UHL, the largest footprint, attributable to adult social care, are very much under control. We've put a lot of work supporting our colleagues, our health colleagues at UHL in making sure that those delays attributable caused by adult social care, so for instance not having packages of care on time, not sourcing placements on time, they're at a minimum at UHL. And the key challenge is actually in the more specialist beds within LPT, so in mental health and on the Agnes unit. And the actions that we've taken in respect to those two units is we have set up regular meetings where senior managers and clinicians sit down. We call it a DTOC flow target meeting, and that's chaired by a clinician. So there's clinical involvement as well as managerial involvement, sitting down on a regular basis, looking at all the reasons for the delays, going back through previous history of admissions to see what learning we can gather from that history, and then concentrating jointly our efforts to ensure that those patients are moved as quickly as possible to the right settings and on to achieve the best outcomes. And whilst we see at UHL large numbers of patients but small delays, we're seeing in some of the LPT units small numbers of patients but very complex reasons for delays. Having said that, I can report that in recent months it's a very much improving picture across those specialist wards. Bradgate unit has, I think, about 12 wards. highly complex, highly challenging patients. But working together, we're trying to get the best results, the best outcomes, and a minimum stay in hospital as far as possible. If we move on to the community hospitals, these are a small number of wards, maybe 24 beds. I think there's in total across those 11 hospital sites, there's something like 144 beds. We have link workers from adult social care who support activity at each of those specialist hospitals. Invariably, these are patients whose journey is that they've gone into the UHL, had a period of confinement there, and then moved into the community beds with a view then to moving home, or alternatively, they may have stepped up from the local community into those beds. Again, the plan is to support them to get them home in as timely a fashion as possible. We have link workers who support that. Those link workers will have relationships with the discharged matrons on the wards. And I can again report that from an adult social care perspective, those numbers are dropping and those delays attributable to actions from adult social care are reducing. Very close partnership working. This week, for instance, we have a workshop with those link workers and the matrons where we're going to sit down and look at how we can work much closer together. What are the key issues that are blocking safe passage for those service patients back home? And then if we move out to the out-of-county sites, the George Eliot in particular, which is a hospital that takes a lot of Leicestershire patients, a lot of patient traffic from Hinckley and Bosworth into George Eliot. We are working, we've sent a letter to the chief executive of those hospitals indicating that at times we're not happy with the reporting, elements of the reporting of those discharge figures. We do believe that to a lesser extent there's a degree of over-recording, although I hasten to add that has reduced significantly in recent months. And again, it's complexity because we've got to make sure that the arrangements on the ground are sufficiently strong from our managers to the ward managers at these sites, which are often miles away. And then that there's a robust accounting for the final report that goes into Unify on a monthly basis at the end of the month, on which all of these figures are then summated and a judgment call is made. And that judgment call, if it's the wrong coding, we only have 2 opportunities in the course of a year to rectify that. So it's a very tight challenge. But again, I hasten to add that from an adult social care perspective, that degree of over-recording is coming down, and we are quietly confident that with the actions we've taken, we will ensure that we reduce that out-of-county challenge. And over and above this, there are very formal boards at the most senior level. John sits on the A&E board, which is the most senior managers who oversight the whole system. I sit on the discharge working group. So there's strong buy-in, strong partnership working going forward. And I think that's about... in terms of actual day-to-day operation, there's senior escalation meetings, which I've mentioned in the report. So, for instance, today we were on a senior escalation meeting, myself and John and Heather Pick, the other AD, working with our health colleagues, going into that micro detail where there are certain issues, certain patients, where across the system we're keen to move those patients on and home or to a different setting, but not a setting in hospital. I think that's about it.
Right, thank you, John. Thank you, Peter. Before we move on to questions from members, could I invite those members from Health and Wellbeing and Health and Wellbeing Board to come and join us at the table? Scrutiny to come and join us. Because I know that we open this up because there is an overlap here with other committees, and it seemed right that everybody gets the chance to put their questions. Then there'll also be obviously an opportunity under a later report as well on the carers for you to join in with us. So thank you for attending today. So over to you, members. Who wants to kick off? Mr. Charlesworth.
May as well be me, Chair. A few questions really. Paragraph 14. where the description of the LLR as one of the most challenged and complex systems. Whose assessment is that? That's my first question. Is it NHS assessment, or is it somebody else's, or our own, whatever? And then paragraph 17, I must be honest, I'm slightly ignorant. Irrespective of whether the delay is potentially reimbursable, just an explanation on that process. I don't quite understand the context of that sentence. Is the experience of people who are already service users of adult social care services, when they go into hospital, is their experience and streamlining better than people who are new and actually then require us when they're in hospital? Is their experience better than new users, so to speak? And then the case examples at the back, it would have been nice to have had a couple of things that had not gone very well, and the day's delay and how that was addressed, so we understand how the problem arose and how it was resolved would have been pretty useful. But what is encouraging is to hear that there is more closer liaison working with partners, matrons and the meetings that are taking place. So hopefully a better understanding between all agencies will lead to better outcomes. But if you could just answer those, please.
I'll go first. So the first question is, who determined that Leicester, Leicestershire and Rutland was a complicated and challenged area? I think that's probably a self-assessment. I think that's an assessment of the fact that we are working in a population of 1.1, 1.2 million people. We only have one acute provider. Now, you might think that would make things simpler. Actually, it doesn't necessarily. That provider is in the centre of the county. What that means is that there are multiple patient flows going in and out of the county. If you look at some of the other counties that are similar size to Leicestershire, they would have more than one acute provider, which would mean that a much larger percentage and proportion of their population would have their hospital services within the county. Quite a large number of hours go outside of the county, which makes managing delayed transfers much more complex for the local authority. We also have a very large provision of community hospitals. Quite a lot of areas around the country now don't have that same level of provision of community hospitals. So that makes things more complicated. In terms of reimbursable delays, this is where the NHS is allowed to fine local authorities for every day that a person is delayed due to adult social care reasons. Now, the NHS can only fine a local authority for acute hospital delays. They can't fine us for community hospital delays or mental health hospital delays, but they can fine us for acute hospital delays. It's within the Care Act guidance. Locally in Leicestershire, that has never taken place. So because we work very well together, because we have a very strong partnership and everybody is understanding of the fact that everybody is doing their utmost, those reimbursable fines don't take place. But there are areas of the country where they do. Notably, close to Leicestershire, the West Midlands would be an area where there are 2 or 3 areas that do fine the local authority for delays. It's a bit of a blunt instrument, really. I think no local authority is deliberately leaving people in hospital. So to fine the local authority for that, and effectively what you're doing is you're saying, this person should be at home, therefore we're going to charge you the cost of the person's hospital bed for the day. But actually all that does is it takes money out of the local authority that they could be using to purchase services in the community. It's a bit of a perverse incentive. Not many places do it, but some do. The experience of new and existing, it should be the same, is what I would say. In terms of our process and our systems and our assessment and our oversight of those people is exactly the same. It makes no difference. The one thing that might be different is if a person is admitted to hospital that has an existing service, say a home care service or a residential placement, and if they're admitted to hospital for a very short period, for a couple of days, then that service will immediately be available again on discharge. Whereas if it's a person who hasn't had that service before, we might have to go out and seek a service, and so that might cause more of a delay. But the process that we undertake is exactly the same.
All right, Mr. Parton next.
I'm looking at the chart that was given this afternoon. Also, with relation to the chart, there's a small chart on page 14. I'm finding the numbers are confusing because there's on page 14, for example, it talks about the NHS England no more than 3.5%, but then we go from percentages to sort of almost sort of ratios. Is there any? Could we maybe have this represented in so it was all in percentages to enable us to slightly understand better what the trends are? Because not all of this, of course, is in table form as well. Thank you.
I think the explanation on the supplementary sheet, I think, explains it a little bit more clearly, that data's coming in from different sources on different levels of analysis, so that there's an equivalence. And I think it might be helpful if, under the actual performance against the BCF target, the second sentence might have a little addition. I think it's correct. This is statistically similar to the target of 3.5%. Would that be accurate? It just makes, I think, the interpretation of the data more clear. And then when you look at the graph, the coloured line blue is what is actually happening, which is beginning to decline from September, is beginning to align with the green line, which is the revised plan, to meet the target of 3.5, so that at the current time, the actual is meeting the target. Just about. If that's helpful. If you think, John, that's accurate.
I think that's an excellent explanation. So what happens is, this is you're right to raise it, because this is one of the banes of our life, actually, in that NHSE set a target saying it's no more than 3.5% of bed days, but then what they do is they report it back to us in terms of a rate per 100,000 population. And the reason they do that is so that you can compare against authority areas. So we might have, I think we've got, 1,900 acute beds in UHL, for example. You might go to Warwickshire, and I'm making this completely up now, but they may have 1,500 beds in acute services. So you couldn't compare necessarily a percentage rate, but what you can do is you can compare a rate per 100,000 population. It's the same across wherever you're looking. But what that does mean is that you get all these figures which it's really difficult to make sense of, I accept. So what happens is that the total number of delayed beds is reported in each month, delayed bed days. That figure is then divided by the rate per 100,000 population. So we've got 546,000 adults in Leicestershire. Over 18. So they divide the figure by 5.46, and you come up with the figures that are in the table on page 14 of the report and in the supplementary. So, for example, in the report where it says on the table, paragraph 27, NHS delays, performance in August was 6.76 against the target of 3.78. I can tell you that as you relate that back to the September data, the latest data, that's 6.2. That's gone down to 6.2. The local authority delays were at 1.26 against the target of 1.33. This is per 1,000 population. In September, that's gone down to 0.8. And so it goes on. So we report in one way. The national target is expressed in percentages, but the performance is reported back per 100,000 population for comparative purposes. And it's a nuisance, I accept.
Mr. Mayor.
Thank you, Mr. Chairman. Firstly, I want to congratulate the officer. This report is very thorough, very detailed, but also easy to understand when you're reading it. But I've got a few questions regarding the risk to the county council and the risk around the smaller amount or the larger amount of £22 million. And it's been made public. You know, the leader's been on radio, on media, and has expressed these issues. But I just wanted to know on paragraph 10, when we're saying that we could lose up to £22 million, you know, how likely is that we'll lose a substantial amount of money like that? Is there a precedent? Has the government come in and taken that kind of money away from Leicestershire County Council? I suspect not, because we would have heard about it, but other councils. So that's my first question. Thank you.
So how likely is it? The simple answer is we don't know. So those, as I said, back in September, when we hadn't signed up to the national target, we were one of 18 authorities that were in that position, 18 health and wellbeing board areas that were in that position. Effectively, the two amounts are, the one amount is the core BCF, which is the Better Care Fund. This is the amount of money that the NHS transfers to the local authority every year, has done since 2015, to support social care services. And effectively what NHS England was saying was, if as a system you are not hitting your delayed transfer of care targets, and if you're not signing up to meet those targets, we will put you into an escalation process. And one of the outcomes of that escalation process is that we would direct the CCGs not to transfer that £22 million to the local authority, to retain it and to spend it themselves in order to reduce the numbers of people in hospital. Effectively, they could purchase their own home care, for example, or they could purchase their own residential care placements, or they could do something different with that money. It's not something that the local CCGs wanted to do, but they would have been directed by the NHS England to do it. The second sum, the 9 million, is the improved BCF that comes directly to local authorities from the Department of Communities and Local Government. And the risk against that one was that if the local authority themselves, not the system as a whole, but the local authority themselves, were seen as not doing everything that they should be doing in order to improve the position around delayed transfers of care, that the Department of Local Government, Community and Local Government, would potentially take some of that money away from the local authority and give it to another local authority that was performing. So they were saying they wouldn't take it out of local government, but they would redistribute it within local government, and they would do that from April of next year. Neither of those two things has been tested, except that we know that there are 16 local areas that have been escalated, and discussions are now taking place around whether or not they will lose that funding. So we've taken that risk away by signing up to the target. Of course, we may not meet the target. It's highly likely that as a system we won't meet the target, and we may go back into escalation. What I would say about the IBCF is, in terms of the local authority, the money that comes to the local authority directly, I think given the progress that we have made over the last, well, since April, every month the delays have come down. We're now 42% ahead of where we should be against our target. We're 23rd in the country out of 151 councils in terms of best practice.
Last month we were 29.
So month by month we are improving our position. I would be very hopeful that DCLG would look at those figures and say, actually, Leicestershire are doing everything they can do. But you never know. There are, you know, we're 23rd, there's 130-ish, 128 authorities that are in a worse position than us. In terms of the other money, the 22 million, if we carry on as we are, we will hit our target for social care delays. But our NHS colleagues probably won't hit their target within the timeframes required. By the time the escalation goes through, which would be into next January and February, I suspect they'll have hit it. So that would seem a bit perverse then to take money away. But you never know, is all I think.
Chair, can I carry on? I've one further question. That's to Peter. Peter, in the report it's detailed that the community hospitals are where most of the bed blocking is happening. Let's be latent about it. Are you working with with those hospitals, you said you were on the working board at the UHL, I think, on delayed transfers of care, or is that including all the hospitals?
No, but specifically in relation to the community hospitals, we are working extremely closely. We've instigated escalation calls, and even John's on that call with the clinical lead Rachel Bilsborough from LPT, who manage those sites. And on Wednesday, we've got a workshop with the lead matrons, discharge nurses, and our link workers and the senior staff to look through what are the key challenges for all staff groups, whether it's continuing health care, packages of care, working together, understanding what the pressures are so that we get solutions which aren't, well, you do your bit, then I'll do my bit, and it's a more linear approach. Let's work as a one team. So we're changing that culture, and I suspect that this will be a series of workshops throughout the course of the winter, specifically looking at community hospitals. So I would say that's the evidence that we are working closely, high degrees of trust, and teams that involve not just managers from the local authority, but nurses and clinicians. And hopefully we're aspiring to get the voice of the service user, the patient, in there as well, in terms of, well, the best outcome is not being in hospital, not being in a community setting, getting a home. And some of the vignettes, which I accept are good outcomes, there are a decreasing number of stories where we could show where it's not worked well, but actually we want to reduce those stories. So that's the evidence that we are working closely with our colleagues in LPT.
Mr. Grish.
Yeah, thank you, Chairman. It's on my question's on paragraph 6, and that's on the high impact changes for effective management, and it's to do with it's the bullet point right at the top of page 12, and that's to do with there's trusted assessors to avoid duplication. I just wondered where these trusted assessors were going to be drawn from.
Trusted assessor is a model whereby you would have one agency undertaking that assessment on behalf of the other agency. So, for instance, one of the key challenges at UHL, or indeed at the community hospital sites, is bringing in a trusted assessor to undertake the assessment for a move into a residential care. And one model is that you get a trusted assessor from providers, agreed to work on behalf of those providers and support quick, timely assessments and readiness of that individual patient to move into a residential or indeed a nursing placement. I think we are in a position across the piece where I think we need to do a bit more work on trusted assessors and getting that model of a high degree of trust and a process whereby nursing or adult social care lead on those assessments. We have a health and social care protocol which looks at tasks and defining tasks and breaking down tasks, but I would say that this is an area where perhaps we need to do a bit more work and to enhance a quicker and timely move on for patients using that trusted assessor model. So that's an area certainly where we need to make progress.
Fiona.
Thanks, Mr. Chairman. I've been associated with Healthwatch now for just over 5 years, and during that time, discharge right across the LLR has been quite a major issue. There have been many ways of trying to tackle it over the years, but I have to say that the last 12 months have actually shown the most significant progress, which is really something to be welcomed. You'll be aware that Healthwatch did a report earlier this year on the lived experience of hospital discharge, which highlighted a number of issues. And quite sadly, those issues were the same issues that you would have identified 2, 3 and 4 years ago. So one of my questions would be, are we confident that we know which bits of the system are currently working or not working? Are we confident, because patients really need to pass through the system in a timely fashion so that as soon as their medical needs are complete, they are ready and can be and are actually discharged to wherever it is that they're going to go for recovery. And you're quite right, you've mentioned it already, the quicker they're out of hospital, the more quickly they are to recover. So there are some issues around that. You mentioned very briefly outcomes for patients, patients' feedback, but obviously feedback from patients is actually key to understanding the impact that the process is having on them. And sometimes patients do have really good suggestions to make, or they spot the little things in the system which actually, if tackled, can improve matters right across the whole system as opposed to just an individual aspect. Secondly, or lastly, just mentioning the trusted assessors. There is quite a history here with trusted assessors' role, where previously assessments have been made, and for example, patients who have come from a care home, an assessment has been made in the acute or the community side that the patient is ready to go and they don't have particular needs. And of course, once they get back to the care home find a vastly changed service user patient with completely different needs and probably quite unsuitable to be in that particular type of care home. So I suspect there is an issue between care home staff and hospital and perhaps social care assessors of a lack of faith in the process. And I think that's something which needs to be addressed and some reassurance gained. So, yeah, those are the key points I think, Chair, I'd like to make. Thanks.
So do we know what's going on, I think was your first question, really. I think we know more now than we have ever. I think our information and our data capture is better than it's ever been and more timely and shared across all partners. I think we have a collective understanding that we didn't have before of where the delays occur and why those delays occur and what the blockages are. Some of those we have managed to overcome, some we're still grappling with, to be fair. So, for example, Peter talked about trusted assessment. We have a limited amount of trusted assessment at the moment. So for it, we have some dedicated rehabilitation and reablement beds in the county that we opened just this year. We do have a trusted assessment process in place for those beds. We have an integrated discharge team that started work 4 months ago now, bringing together County Council, City Council and NHS colleagues into an integrated discharge team where previously we had 4. That's working quite well, and it's developing that trusted assessor model whereby one person can assess on behalf of other agencies. We've got the new Help to Live at Home process, which is a trusted assessment process on discharge for reablement. There are still some areas where we don't have that in place. One of the ones is the care homes issue. So we have been to Lincolnshire. They have a system whereby the providers all collectively employ one person to assess on behalf of all of the different care home providers, and they work within the hospital so that the care homes have the confidence that if that person says that this person is fit for discharge and can come back to the care home, they've got that confidence where they may not have it with us, as you've pointed out. So I think we know more about where their blockages are than we ever have, and I think we are in a better place to address those. Funding is still an issue, which we are addressing, and I met yesterday with the Managing Director of one of the CCGs to agree a funding process for people who are in hospital where we need to jointly fund them on discharge. So we are trying to tackle those issues that have bedeviled us for a number of years.
Richard.
Thank you, Chairman. It's a very good question, Fiona. I mean, the reality is the big picture is that the government is short of money, the NHS is short of money, we're short of money. What that leads to is what we're actually doing across everything that adults and communities do, which is trying to solve the financial problem in a way that solves the patient's problem. And everybody out there would think that the NHS and social services would be hand in glove together, working very closely, looking out. So I think one headmaster said to me once, the moment a pupil arrives in his school, he's thinking about that pupil leaving. The moment that somebody arrives in a hospital, they should be planning the exit. Maybe in many areas that hasn't happened. Different organisations, different approaches. What John's outlined is what we are trying to do. We are trying to use our best practice to reach to the NHS, and they, because they can't keep having more and more money, hopefully are reaching to us to see that it should be equal. Obviously never is, but the idea is that we've got to find a whole myriad of small little changes in the way we work that will make the difference. Can we say we've got enough at the moment on the table? The answer most likely is no. Are we on a learning curve of improvements and finding lots more ways almost every month that I meet with people on my right here? There's new initiatives, new ways forwards. To me, the patients will get a better outcome by us working more closely. We hopefully will avoid the financial pressures, and hopefully we might be able to help the NHS. But there's a lot more work to be done.
Chair, just if you'd allow me, just something niggling at me. A question for John. When did we find out the timelines? Was it in July we found out when we had to hit the targets in November? Chair, which to me that's ludicrous. You know, how are you supposed to hit a target 50 or 60% below where you're at in a quarter? Somebody's got, obviously got it wrong in central government, and we need to address that. Thank you.
I think it's often the way that central government and the NHS don't appreciate the outcome of the decisions they make. I think we can take heart from the work that our officers are doing. I think it's clear that those discharges under our control are doing very well. Clearly our officers are trying to work very diligently and in partnership with NHS. In some ways, paragraph 44 tells the story. And I think it's worth just bringing to note that a lot of this is not under our control, but we may be penalised for it. So I actually agree that it seems a perverse calculation, but I'm heartened by the fact that our officers have answered the questions that have been put and are really working day and night to make sure that we achieve these targets. And the latest figures that John has kindly provided today, hot off the press, I think show that trajectory. So thank you for that.
May I just ask a question? Could we request that somebody from the NHS comes to talk to this committee about what they're planning to do? Bear in mind that we're working so hard.
We could request. Whether they come or not is another matter. And again, it would be finding someone from the NHS that would actually take responsibility, I suspect, and answer. I'll be guided. Yeah, we're passing that one on to Health Scrutiny Commission.
That's all right, because I'm on that one as well.
that was good. I'm pleased these people are sitting next to me. Oh, sorry.
If I may, Chair, thank you for letting me speak. Just a couple of small points. Obviously, I've not studied the report as well as everyone else has today. You did sort of mention earlier where you think we might hit the target of early next year. You'd be able to be a little bit more specific of when you think we might hit it. And also, Leicester City and Rutland, do we know where they are where they sit within the targets as well, please?
I wouldn't want to be too specific because there's a camera, isn't there? But we set a target our original plan was that we would hit it by March. We are, if you look at the charts, we are still on the trajectory to do that. I suspect we may hit it slightly before that, but certainly I think that, with everything that we are doing and everything that we've put in place, it should be entirely possible to hit that target in the new year. In terms of Leicester City and Rutland, I've got a table here of all 151 authorities. I did mark Leicestershire, but I haven't marked the other one. It's very small writing. What I can tell you is that in terms of the local authority areas, this is just from an adult social care perspective, Leicester City is 11th, Rutland is 10th. As I said earlier, we are 23rd, and they have a similar level of... in terms of NHS delays, they are similarly challenged in the same way that we are, in that the NHS are not meeting the targets currently.
So they're pretty much in a similar situation
yes.
to what we are really as well?
Yes.
Okay.
All right, thank you for that, Peter and John. We'll now move on to agenda item 9, which is the impact on social care of the national living wage and payments to staff for sleeping and living care. Quick change of personnel. So over to Sandy.
Yes, thank you, Chair. This is an issue that's been subject to quite a bit of media attention over the last few months and relates to payment of national living wage for working time, particularly as it relates to staff who have duties where they're required to be at work, mostly for sleep-in duties, so where they are at work, they're on call, but they're allowed to sleep during that period. And by and large, those people have received a lump sum payment for that rather than an hourly rate payment. And there's been a level of uncertainty for some time as to how the national living wage would apply to that. That really uncertainty is now no longer there, because as a result of recent employment tribunal outcomes, staff are entitled to national living wage if they are required to be at work, i.e. if they couldn't leave the premises, or they're subject to disciplinary action if they left the premises. So that point is now clear. What that means is that there are a large number of employers who have employed or are still employing staff to undertake sleep-in duties, who are now subject to scrutiny in relation to that, and staff who could take further employment tribunal action against them, and HMRC could fine employers who aren't paying the national living wage. So there's a lot of activity taking place nationally in addressing this, and particularly a number of larger organisations providing services to people with learning disabilities are very concerned about the impact this has on their financial viability, because it's not just the costs of paying national living wage going forward. This issue is staff potentially have an entitlement to 6 years of back pay in relation to that, and HMRC can take enforcement action up to another additional 200% against employers who've breached their national living wage requirements. There's still, I think, a lack of certainty about what HMRC are going to do in relation to that. They have put on hold any action currently, and there are discussions taking place at a national level about a national kind of resolution to the issue, but as yet there's been no announcement as to what HMRC are, what final position they're going to take. The report really outlines what the implications are for Leicestershire in relation to the national living wage, both for the council's own directly employed staff, and there are a small number of staff who undertake sleep-in duties within the county council who are still receiving a block payment for those, but those staff do receive a higher hourly rate, and their average hourly rate would still meet the national living wage requirement, and it's our understanding that that is compliant with the requirements. There are a much larger group of staff who are affected, who are employed by voluntary and private organisations, many of whom are in services commissioned by the council. And those employers are obviously now assessing the position and will be required to pay national living wage, and are looking at the implications in relation to any back pay. And the councils ensure that our framework agreements for providing services are set up in such a way that the rates we pay are sufficient to pay national living wage, and we require that those employers do pay the national living wage. The group of people who are affected who receive direct payments, so these are individuals where the council's not commissioned to care about making a direct payment. Some of those people will have employed staff to undertake sleep-in duties. I think we've identified most of those, if not all of them, and we're working with them to ensure that they currently receive a direct payment that will enable them to meet their obligations as employers. I think there are a number of commissioning implications for the council. As I said, we've ensured that our new commissioning arrangements going forward will be compliant with the requirements of the National Living Wage. The big outstanding issue is what will happen in relation to any back pay claims that may arise. Given the levels of uncertainty about what action will be taken and what HMRC's position is, I think it's very difficult to quantify exactly what those are, but clearly of significant concern to providers. And there's concern that we'd have as commissioners about the impact that might have on the stability of providers if they were required to pay very large amounts of back pay and fines. The resource implications going forward, we've calculated a potential of 315,000 in terms of what the additional annual cost would be of additional fees we would need to pay in order to meet national living wage. We haven't made a calculation yet of what any back pay issues might be, but that current responsibility obviously currently rests with the employers rather than directly with the council. And we're doing further work to understand what the cost implications would be in relation to people who receive a direct payment. So I'm happy to take any questions that members may have.
All right, thank you, Sandy. First of Mrs. Broadley.
Thank you, Chair. I actually welcome this report, and I'm very pleased to see that the County Council actually pays above the living wage, so therefore it doesn't have any impact on the sleeping arrangements, and I'm sure that our staff are pleased with that. The other thing I'm delighted about, and I did ask the question earlier, is about the procurement. And the fact that it's now going to be, or it now is, written in that providers have to pay the living wage to be able to take part in the procurement, which is good news for people working for these. The only thing I would say, I would like to think, and I don't know because this is adults and communities, I would like to think that that's involved in the procurement across the County Council and not just in this area. Thank you.
That definitely is the case in relation to the procurements we've undertaken. I think we need to clarify exactly what the position is across the council. Having said that, the numbers of sleep-ins that would be affected anywhere else would be very small.
Sorry, I perhaps didn't make it very clear. It was just the fact that whatever procurement the County Council does, not necessarily into relation to sleep-ins, but across the board, that the council would require anybody that wants to go for the procedure to pay the living wage to their staff.
Well, I think it's illegal not to these days, so we have to. So
we can seek confirmation of that from Corporate Commission colleagues post the meeting.
Mr. Jennings.
Yes, thank you, Chairman. My understanding of the situation is that when a member of staff does a sleep-in, they get a fixed fee, and then if they are called from their beds during the course of the night, they get payment for the number of hours that they're on call or out. Now, this claim, and I seek clarification, and the minimum wage, is it purely relating to the time if they're called out of their beds, they're on duty, or is it across the board, so for a fixed fee of, say, a 10-hour shift or something like that?
I think to clarify, what the law now is that any time that you are required to be at work is working time, and for that time you must be paid at least the national living wage. So that includes the time when you're not required to do anything other than be there. So if you're asleep, for instance. So it is no longer allowable to say we'll pay a lower rate for the time that you're asleep and just pay you at the national living wage for when you're awake. It applies to the whole period. So you must receive across your whole working week for all the hours that are working time, which includes sleep-in time, you must on average receive the national living wage.
John?
Just to clarify that, so in effect you can be paid lower than the living wage for the time you're asleep. If the time that you're awake, you're paid above the living wage, so that it equals out across the piece that you are paid the living wage for the whole of the time that you are at work. Does that make sense?
Mrs. Fry.
Thank you. I think this is quite a complicated report. It looks, on the face of it, oh yes, everybody's getting the right money for the right job. I presume this is having the same effect as our last report we looked at, that we're not the only council in this position, that everything else. I also presume it's for all other services, not just health and well-being, but fire, police, everything, Coast Guard, you name it, anybody that could be on call. This is a huge effect across the country. My question is that in the figures, we're talking about the national living wage, the national wage and the national living wage. The figures that are quoted, does this also include pensions? Because this would have a knock-on effect on pensions, I would presume, because nowadays I'm given to understand that everybody is supposed to have a pension, and it's normally based on your income. So I'm not sure on that.
Okay, I'll try and answer those as well as I can. The ruling here is not about all on-call time. So there are people who could be on call, but they're actually not required to be at a particular place at a particular time. So I think the difference between that's applying to sleep-in arrangements here is that these staff, they're on call, but they're also required to be on the premises and available on the premises. I think that's the key difference in terms of why these particular groups of staff, that's been categorised as working time. So I don't think the issue applies to everybody who is on call. And there are a set of criteria which the Employment Tribunal set out, which say this defines when somebody has to be paid, and it wouldn't apply to somebody who was on call but could, for instance, go about their normal business and wouldn't be required to be in a particular place. In terms of how the issue would affect pensions, my understanding would be that staff would be paid for that time. That would count as working time exactly the same as other working time, and would impact on the level of salary they received, and that would have whatever impact it would have on their pension contributions. So effectively it would mean that staff would be working more hours and would therefore make increased pension contributions.
Just ask a supplementary, please, and that is that if it was proven that we had to go back 6 years, or 4 years, or 5 years, would that have any effect on the pensions, or are we just paying them a salary, the back pay?
I'm afraid that really goes beyond my competence to answer. I don't know the answer to that. But just to be clear, that any payment of back pay is a responsibility of employers. There is so the liability here in legal terms falls on the employer and only directly on the council, where the council is the employer. Clearly there would be commissioning implications that the council would have, but the responsibility is an employer responsibility.
Mr. Meyer.
Thank you. Just on that same thread, on the financial liabilities that the providers may face, there has been speculation that providers could go under because of the implications of back pay. If you've got to pay for a year, you'll be able to absorb that into your costs. But 6 years, 7th year in total, Leicestershire providers might not be able to absorb that cost. And we've seen with the Help to Live at Home where if a provider does walk away or does go bust, it causes chaos. have we thought about the implications? Have we put into our thinking that if in March 2018 the appeal is unsuccessful and then the employees have to pay back pay for 6 years, we're looking for a sum of nearly £1.5 to £2 million for those providers. Would they be able to cope? And what are the implications, what are the risks if they can't, to Leicestershire residents? Thank you.
We are looking at that issue, obviously. There is a difference between those providers that are national providers and those that are local providers, in terms of the process that we go through and the involvement of other agencies. So, for example, if it's a national provider that gets into financial difficulty, the Care Quality Commission have a role to play. If it's a local provider, then our own quality improvement teams and contracting teams will be responsible for overseeing some of the work around that. We do obviously plan for situations where we may need to bring in new providers or to provide cover arrangements. We won't know for some time what the position on that is, I suspect. I also suspect that the liability on providers may yet need to be clarified in terms of the government's position. They've taken 2 months, as Sandy said, to undertake a national piece of work to look at the implications on providers. Within that time, they've issued at least 2 pieces of guidance, both of which refer to the amount of money they've given to local government over the last year, and the amount of money that they will be giving to local government next year. And I wouldn't yet be surprised if there aren't conditions attached to some of that, which might, in fact, make us liable for some of that debt.
Cheers. Thank you. That was my yeah.
Right, thank you, members, for the questions. We'll now move on to agenda item 10, which is the draft Leicestershire and Rutland Carer Strategy 2018 to 2021, and is still with Sandy.
Thank you, Chair. What we've bringing to you today is the draft.
Oh, sorry, Sandy. Before you carry on, there's some further members that need to come and join us. We're a growing family. Apologies for missing you, Mr. Sheehan. Sandy, back to you.
Thank you, Chair. I said what we're bringing today to you as part of the consultation process is the draft joint Leicestershire and Rutland Carers Strategy. And this is not the first Carers Strategy that we've had. And the issues around carers are probably fairly well known to most people, and that carers are absolutely the backbone of the health and care system. And in fact, we talk a lot about the responsibilities that commissioners have. We talk about services, but actually the great majority of care and support to older and disabled people that's delivered in this country and in Leicestershire is delivered by carers, unpaid carers. And it's really vital that we support carers to carry on caring. And I think there are a lot of really good reasons for doing that. It's the right thing to do, but also actually it's the only way that we'll create a sustainable health and care system is if we get support right for carers, because if carers aren't supported to carry on caring, there's no way that paid for care could fill the gap. There is no way to make things work other than for carers to carry on being that backbone. So what the latest iteration of the Carer Strategy is doing is setting out some overarching priorities for how we can work together with our colleagues, particularly in the NHS, but also other colleagues, to support carers. The strategy that's in front of you has been developed by a multi-agency group of the 3 local authorities, the 3 clinical commissioning groups, and our partners in the voluntary community sector and carers organisations have developed a draft strategy, and the plan is to consult on that draft strategy starting either later in December or from January, consulting on that strategy with a view to developing a 3-year strategy, 2018 to 21. And this is still very much a work in progress because it's still got to go through all the various governances of the partner organisations and be subject to, say, public consultation. So there's a lot to do in terms of that, further developing that. But it's been agreed by Cabinet to go out for consultation, and that consultation will be starting. So we very much welcome your views so that can feed into that consultation process.
Right, thank you for that, Sandy. I very much welcome this report. I think it's an excellent piece of work and shows the benefit of a multi-agency approach, and particularly going out. And I think Dr. Bremner wants to kick off as the first points about the consultation.
Yeah, a front end of a consultation is what the public sees in a questionnaire and the design of the questionnaire. Just some comments on the layout. On question 5, and then the previous question 4, I'll start on question 4. There's small boxes that enable the respondent to tick, which is fine. But then in question 5, the same size of box is used to enter a number. So I think that probably needs changing. Question 7, the boxes corresponding to the statements are a little bit adrift and might want sort of closer attention to the statement. And on question 12, the line for the address is just a single line. So you might want to have another line there for people to enter their address. And then I'm not sure about the next 2, but there might be some legal requirements now for question 13 of the options you give and question 20 of the options you give. But I don't know. But that's just, I don't need any comeback on that, just some observations, yeah.
Mr. Sheehan.
Thank you, Chairman. I was trying to work out a little bit what the basis of my invitation here is today, and I noticed that there's quite a bit here on young carers, so I presume that's where I jump in now. I'm interested to know if there's a model of best practice that officers have drawn upon with the approach to supporting young carers, because I do have to say that I think some of the things that are stated there under Priority 8, page 57 or 21 of the document, are somewhat aspirational, maybe a little vague. I don't know if that's deliberate because it's at a consultation stage. But also it seems a bit loose and ad hoc. And also, has any thought being given to the costs of providing the extra support that may be needed? Because clearly, if you're providing the opportunity for children to pursue their education in a more structured way, and giving them time off, somebody's got to take up that time that's otherwise given over to caring. So I just wonder how much thought's been given to that.
I'm really pleased that you thought the strategy was aspirational. It is, and I think the reason that it isn't tied down into specifics is this is a strategy that's spanning 3 local authorities and 6 partner organisations. And I think from that point of view, in order to create that kind of strategy, we do need to have it reasonably high level, because there will be implementation plans sitting below it, which will really be based on a local authority footprint, where there'll be much more detail about how we will do it. So I think the strategy is written in such a way that it's enabling, that it is aspirational, and what we'll have sitting below that are some much more detailed implementation plans about how we're going to improve the offer in our local area. And it will be different in different parts of Leicestershire and Rutland. The carers offer will not be identical. The services configured differently. The voluntary sectors are organised differently. Carers organisations are different. So a lot of that detail will sit beneath the strategy, and there will be a county implementation plan which will spell out in much more detail what the offer would look like and what the approach to young carers would be in Leicestershire.
Okay, so that, if I may, Chair, that's the next steps. When can we expect to see this work reach that stage? And also, as I said at the start, is there a model of best practice that you're trying to follow with this?
The implementation plans is still being developed. So what we're trying to do is get the high-level strategy signed off, and then there will be an implementation plan. I'm sure we'd be happy to share that at a later stage with the committee. In terms of that model of best practice, there has been there was a national consultation on what the national care strategy should look like, which concluded in middle of 2016, and the government still hasn't launched a national care strategy, and there actually isn't a date for the launch of the national care strategy. What we understand is that the carers' work is now going to be rolled into this much wider review of adult social care in a new green paper. So it's going to be quite some time before a national care strategy emerges. So I think that it would have been helpful. I think we would have been better, I think, to have had a national care strategy and then roll out our delivery of it. But we're not in a position to do that, and we certainly don't want to sit about waiting indefinitely for that. So that's why we're trying to bring this forward now. There are models of good practice that exist in relation to a whole range of carer services, and we'll be really keen to use those. And I think there's already good practice within Leicestershire in terms of the Bernardo service, which has been commissioned, and a lot of good work to build on in Leicestershire.
John?
I just wanted to just briefly add to what Sandy said. Notwithstanding the fact that we haven't got the national strategy, what we have done is we've consulted with a very large number of carers in Leicestershire, including young carers, and what you see in terms of the priority areas are the areas that they have suggested that should be priority areas. So we are taking account of what the local views of people are.
Mr. Mayor.
On what residents are claiming for carers allowance, and what they're claiming and what actually they're entitled to, Leicestershire residents are entitled to. There's a massive gap. 35% of all carers allowance goes unclaimed. Is there something already in place, or is there something that we can put in place to highlight the carers allowance and get people to apply once we identify that they're carers, be it young carers or people entitled to carers allowance? Because obviously if that funding isn't claimed, it puts extra resources and pressures presumably on the county council.
Yes, absolutely. And there are a very large number of carers nationally and locally. I mean, if you look at the census, you're looking at between 10 and 12% of the population who identify themselves as carers. So these are very large proportion of the population. Just on that basis, there's like to be one or two carers in this room in terms of just the normal incidence. Where we know carers, we are obviously encouraging them to claim what they're entitled to. And the voluntary organisations that we're supporting are very much encouraged and are identifying carers and helping them to make those claims. So we are actively promoting that. But given the numbers of carers and the fact that many of those people, are very undemanding, actually, very prepared just to kind of get very stoical, very much kind of getting on with it. That actually, this is a group of people that you actually have to work quite hard, I think, to make claims, and that's something that we would definitely want to encourage and carry on with.
Thank you. Sorry, Mr. Charlesworth.
I'll be brief, Chair. Sandy's emphasised the point that we can't sit on our hands in this authority and wait for national government to get a carer strategy going. We need to get going as best as we can. What I don't want is the national government to say, actually, we've come up with something in 3, 5, 10 years, or however long it's going to take them, and then come in and tell us that we've been doing things wrong. I'd sooner we got things done regardless, instead of waiting for them to get off their backsides.
Absolutely, we would agree 100%. So, as Sally said, we haven't got the carer strategy. What we did have is the consultation document that preceded it, so we have used that document in terms of knowing the areas that were being considered by national government. When we went to Cabinet in October to seek approval to consult on the carer strategy, we also sought approval to, as we consult, to actually start to implement those things which from a county council perspective we can implement now. The things that carers have told us that we need to do, rather than wait for the consultation, wait for the strategy and wait for the implementation plan. There are certain things, and it's in the report, page 32, paragraph 8, 38, some of those things we can just get on with, actually, and get on with and do them now.
Thank you, John, for that. And again, it's I think it's credit to officers that they're keen to get ahead with these things. From my own point of view, just to address one request, could somebody make sure we do electronically test the form so it can be filled in electronically? Because I know what it's like when you try and tick a box electronically and you can't. It's somewhat frustrating. You don't need to answer that one. And I think a sense for all members that once we've got a better idea of the implementation timescale, could we have a report back to this group and invite others as the case may be, so that we're all aware of the strategy timetables once things have become a bit clearer. All right, thank you for that. We'll now move on to agenda item 11, which is the Adults and Communities Local Accounts 2016-17. And I don't know who's doing it. Is it Amisha or?
I'll kick off and I'll hand over to Amisha.
You can work it between yourselves.
Thank you, Chair. If I can introduce Amisha Chauhan, who is the main author of the report and has done a lot of work on the local account. So this is the 7th local account that we've brought. So I'm not sure if there are any members of the committee who've been here for all 7. But I think I have. So the purpose of the local account is to try and present in an accessible way a picture of how well adult social care services are performing in Leicestershire. So it's very much intended that it's written for a lay audience to try and explain what's working well and what needs to be further improved in how we're working within Leicestershire. So hopefully we've been able to do that. It's no longer a requirement that we produce it, but we have carried on doing that on the basis we think it is important in terms of accountability and transparency, that we do tell the story and feedback to the public what we're doing. So what we've set out here is our performance in 2016-17. So from that point of view, it's never kind of completely up to date. So it's not describing to you what the performance is today. It is looking back at what performance has been. One of the reasons that it isn't so current is that we need to build into this the performance information, which isn't available at the start of the year. So that's why we bring it in the autumn. And what we're trying to do is just describe not just the kind of dull performance metrics, but actually giving some examples that hopefully explain the narrative, the story of what it's like to receive adult social care in Leicestershire. If there's any points of the detail, I'm sure Amisha will be able to help you out in terms of answering any questions about how it's been developed and the content of it. Thank you.
Right, Mrs. Broadley first.
Thank you, Chair. The graph on page 94, performance, very good to see 3 points that are outstanding. But I want to ask about the 2 that are the two that are number 2, adequate, ensuring that people have a positive experience, and supporting carers. We've just had the report on supporting carers, which is good. But I would like for you to drill down on what areas that this is. Excuse me. Does it cover elderly persons? Typical. Is it somebody with a learning disability?
If I could start there, the first thing I want to make really clear is that these are actually self-assessment ratings. So these aren't ratings that somebody else has come in and assessed us. These are our own ratings about how well we think we are doing. And I'd say, Misha may want to add something, but I think the key things here are what are our customers telling us about their experience. And if you look at there are 2 surveys which are undertaken. There's an annual survey of service users, and there's a biannual survey of carers. If you look at some of the feedback that we receive from our customers, and this is using a standard national methodology, so we can actually compare what people in Leicestershire are saying with what people are saying elsewhere. Our feedback's pretty mixed on both of those. We get some very positive feedback, but some of our customers are less satisfied than customers in other areas, and that's both true for service users and it's true for carers. So I think that's the main reason why we've rated ourselves as adequate there, because I think unless you're getting consistently good feedback and feedback that's better than average, I think it would be quite hard to rate yourselves as good. So I think that's probably one of the main reasons that those are rated as adequate. In terms of who's saying those things, I mean, it's of the surveys of all. It's a representative group of all service users, so it would be representative of the whole range, age range, people with older people with learning disabilities, people with mental health problems, and carers. Again, it's the carers who've used our services. So by and large, these are carers of older people, but they'll be representative of all the carers that we work with. I don't know if there's anything else anyone would like to add.
Just on the self-assessment under ensuring people have a positive experience, we do look at the ASCOF. So say, for instance, one of the ASCOF examples was social care-related quality of life, and we did actually rise on that from 18.5 to 18.9. So I think we've just been a bit harsh on ourselves and put a 2. But when you look at the number of compliments have risen. Complaints have gone down. We're making it real, co-producing. So there are some really good examples of, work that's being done.
I do welcome the report. You'll have to excuse me doing the Theresa May, which for me is a bit, but there you go. Yeah, cough, cough, cough. The report is good. I mean, the outcomes that you've got there. But it's just that if there are, and I appreciate that it's a national survey, but if it could be adapted so that locally we will know if there is a certain group that feel that things are only adequate, so that we can improve on that. I mean, we've got, as I say, 3 outstandings, which are absolutely fantastic, but it would be nice to get everything above the adequate. So therefore, if you could just look in the future to look at whether we can drill down a little bit more locally and find out if it is a certain area.
John, I think you wanted to.
Certainly, there is some work that we are doing. We have our colleagues in the council are helping us to drill down into some of the information in a way that we haven't been able to previously, using some of the new technology that we've got. It is an anonymous survey, so we can't identify people, but there are some demographic characteristics that we can identify: age range, we can identify gender and So there are certain areas that we can look at. And of course, we always feed back to people. We always offer people feedback in terms of the completion of the survey. In fact, the latest carers survey results, the feedback leaflets are going out as we speak this week, I understand. And within that, we will ask people if they want to be further involved and if they want to come and talk to us about some of the responses that they've given, to tell us why they responded in the way that they responded. As Sandy said, it's a mixed picture. On some of the things we do very well, but there are others that we consistently have satisfaction responses that are below the average, and we need to understand why that is, and if there's any particular reason for that. And some of that is not to do with social care, some of it's just to do with people's general feeling about themselves and where they live and their experience more generally in life. But nevertheless, they are all people that we have a contact with, so we need to make sure that we understand what's happening for them.
Mr. Charlesworth.
Thank you, Chair. I think I've been here for all 7. I'm sure I have. Time flies. And yeah, it's a valuable sort of state of the nation piece for me, and I hope we do continue with it. But of course, these are only ever good if they drive improvements in service, if they improve performance. So it's taking the information that we get out of these and implementing it. I have one slight criticism or observation on page 99. Our population, the table there, it could be me, so I'll leave it open to debate. I looked at the last line, people aged 90 or over, from 2017 to 2030. That's doubled, more or less, in size, yet we only call it a 49% increase. That's a 94% increase in my mathematics. My mathematics may not be right, of course, but I just think if we're going to quote figures, we do need to get them right, please. Thank you.
Very good point. You can do my tax return for me next. Fiona.
Thanks, Chairman. I think Healthwatch normally have an opportunity to pass comments on this. I don't think, have we had this yet?
Not yet, after this.
Right, okay, right, that's great. So I'm getting in early then. Okay, I think it's really difficult, given that this is 11 pages, to fit a real flavour, more than just a little flavour of what's going on in the world of social care. So well done for getting as much in as you have. A couple of questions. In the general layout of the report, have you given the draft to any service users to read through, to give any feedback on how it comes across to them? That might be helpful in terms of finalising the picture of it all. Is there room for a very quick overall summary? We've done okay, but we're going to do better next year, or you know what I mean, something a little bit more meaningful than that. And is there room also, we've mentioned under the compliments a couple of responses from service users. How about getting something from members of staff that are out there actually delivering services to people, particularly people from social care who are out in the field, getting some response? It just promotes a little bit of understanding and a flavour from people out there that actually there are lots of people trying to do a really good job for them to help them. And what about a feature, one feature per annum, per report, on a particular aspect of work from the department, just to give a flavour? Because, let's face it, this is about work that's already been done. But even, and it's interesting, I think it's interesting, to a lot of people, but not a lot of people understand the full range of what goes on in adult social care. So perhaps there's room for just a little box to say, you know, this is what we do in one particular part of the department. Just a suggestion. Thanks.
Thank you for that. I think there are things we could learn from your good selves in terms of graphics and presentational. Your Healthwatch's reports are very presentable, very readable. And so we'll have a look at that. I think we were trying our best to keep it as brief as possible this year, and certainly myself, possibly other colleagues, but I know that I've asked for lots of reiterations and edits, and Misha's probably fed up of the requests that I've made, let alone everybody else. But we will look at that and try and take on board the comments, because we do need it to be readable and understandable by people. That's absolutely key. If people can't understand it and read it, there's little point producing it, frankly.
Thanks for that, John. Following on from what Mrs. Broadley said and your response, if there is any opportunity to tweak the questionnaire on the previous report to provide any more granularity back from carers, I think we'd all appreciate that being done. If it provided more information along the lines that you wanted, and certainly Mrs. Broadley wanted as well, we'd appreciate that. So thank you for your time there, and thank you for those reports. The date of the next meeting is January the 16th, 2018, which is after Christmas, of course, so we can get that out of the way. There are no urgent items, so can I just thank everybody for their input into today's meeting and being here. And the first of many, I'm sure that I can wish this committee a Merry Christmas. No, not until December.
He never brought them when he was chair of planning. I used to provide mince pies and sherry. To who?
Himself.
Yeah.
It's not fair, is it, David? You did all that.
He used to work for Sainsbury's and get it for nothing.
A lot for nothing there.
No, I took it round.
David, are you going to the... See you then.
Well, yes. My wife took me out for the weekend.
Just take you out next week to report, Joseph.